Welcome to the third and last part of week 3 on cost estimation for economic evaluations. In the last part, we did exercises to do with time preference, and we began to look at different kinds of costs like capital costs, where we did an example of annuitization. And we spoke also about overhead costs and the difficulty of what we call allocation. So in this next part, we're going to look at other kinds of costs. And by other kinds, we mean in the realm of productivity costs, which allow us to do analysis from the societal perspective. If you have forgotten what perspective is all about, it is a good idea to go and review the slides on perspective. So let's look at productivity costs and their measurement. Productivity costs are defined as costs associated with productivity loss and replacement due to illness, disability, or death of otherwise productive persons, both in the paid labor force and in the unpaid labor force. But there are some other definitions out there which also value, lost leisure time. And there's a good indirect cost chapter in this book by Gold et al. 1996, the US panel book. Some of you will be familiar with that book. And the estimation includes estimation of the length of absence from work. And there are several validated questionnaires like the Work and Productivity and Activity Impairment Questionnaire, the WPI. And the problem is that they may not capture the disease of interest. So many analysts actually use non-validated questionnaires. But the idea here is to measure length of illness, illness due to the disease. So just to go back, remember we said that in the estimation of cost, you have identification, measurement, and you have valuation. So in this slide, we are looking at the valuation of productivity costs, and there are 4 methods. One is the human capital approach. We talked about this a little bit under cost benefit analysis in week 2, but essentially use potential earnings for wage and non-wage workers as a proxy for the cost of lost time due to productivity loss. The next one is the replacement cost method, which is essentially the cost of a replacement worker, replacing the person who is sick. The third one is the friction cost method, which is based on the cost of training a new worker to be able to do the job of the worker who is sick. And then the last one distinguishes between time invested in treatment, which is time for treatment, and illness costs or mobility costs. And for mobility costs, it recommends capturing them under quality of life or as a utility loss. And they caution against what is referred to as double counting. So if you count the costs, if the quality of life estimate in a cost utility analysis includes the utility loss due to illness, due to lost wages, then you shouldn't count it as a cost essentially. And this approach is recommended in the Gold book, in the Gold panel, which is the panel on cost effectiveness in healthcare in the United States. So these are the 4 methods: the human capital, replacement cost, friction cost method, and what we're calling here the Gold panel approach. The other part of indirect costs is the costs of informal care. Remember that all of these, productivity loss, productivity costs, and informal care, are indirect costs. They are indirect costs. And the other 2, besides indirect costs, are direct medical costs and direct non-medical costs. So those are 3, 1, 2, 3. Direct medical, direct non-medical, and indirect So informal care is part of the indirect costs, and it refers to informal care provided by family members or friends or care agencies. And it's important to include this for diseases where they may be a substantial proportion of the total cost. So maybe for someone with Alzheimer's disease, where they're going to spend a substantial amount of time in a care home. The measurement may be using diaries and also by doing surveys where individuals have to recall the amount of time they spent doing informal care. And with regard to valuation of informal care, you can use the opportunity cost method, which calculates the cost of informal care as the value of the best alternative use of people's time, which would mean maybe they lose leisure time or they lose work, and you need to put an estimate on that. And if the caregiving hours could be used for formal paid production, then the value of informal care is equal to the value of this production, which is what I refer to here as work. Now we're going to look at the World Health Organization costing guidelines. So the World Health Organization has, a wonderful resource for costing, and it's called the WHO Choice website. And WHO choice refers to choice. The word choice refers to choosing interventions that are cost effective. And WHO recommends a micro costing approach under the following categories. You have costs of providing interventions or resources like labor, buildings, and space. Then you have costs of accessing interventions, transportation and time costs. So these are direct and medical costs. Then you have program costs, and then you have productivity costs. And it recommends including these ones separately because WHO generally uses DALYs averted as the outcome measure. DALYs averted. And as we shall see next week, DALYs averted do not include productivity. They just count years of life lived with disability and years of life lost. So the combination of these two is equal to DALYs. But I'm going ahead of myself because we're going to speak about these next week. And the resources here are these 4 websites. You'll find, health service delivery by country, program cost by region, prices and useful life of tradable capital goods, and prices of recurring tradable goods. So I encourage you to visit these websites because if you are interested in actually doing a study, they will turn out to be very useful resources. So here's the health service delivery web page of the WHO. I wanted to bring it to your attention, and you can do it by country. So if you're doing a study in Eritrea, you'll just go down here to Eritrea and click on that. If it's in Gabon, you'll just go there. And if you are interested in Bahrain, then there you will be. So essentially, I used Afghanistan, which is the default, the first one. And it turns out that for public facilities in Afghanistan, the cost per bed day in a primary level hospital is here, $4, $4.7. In a secondary hospital, it's $4.9. In a teaching hospital, it's about $6.3. And you can do that for, this is in international dollars, And the cost is given in local currency and then also given in US dollars. So you have 3 estimates: international dollars, local currency, and in US dollars. So you can choose whichever you want to do. Then this is for inpatient, and it has an estimate for outpatient. So if you're doing a study in another country, all you need to do is put in the country and you'll get estimates of these. So it's a very nice resource if you're interested in actually doing a study. So I encourage you to visit the website and take a look at that. So here's the WHO Choice Program Cost page. This is the price of local non-traded goods. And you'll find things like administration, finance, health personnel. You see things like media. You see operational costs for vehicles, electricity and water, rental prices, per diem and travel allowances, the capital cost of buildings. So you have many cost estimates on this website. And here's the capital cost website, and you'll find that you have useful life estimates if you want to annuitize for tradable capital goods, essentially. So a car is 7.3 years, an air conditioner is 9.3 years, a computer is 5.4 years. This will have to be a very strong computer. This is a strong machine because mine tend to last 1.5 years. But anyway, you have things like desks which are nearly 8 years and so on and so forth. And here is the recurrent cost page, and here you'll find things like paper and pens and envelopes, really small stuff, but you have estimates for these, and these estimates are by region. They are by WHO region, so they can be really useful in performing a study. If you're doing a study, these are going to be very important resources for you. I also wanted to give an example of a unit cost of drugs, unit cost of medicines database. And this is the MSH, Drug Price Indicator. MSH is Management Sciences for Health. And essentially what happens is that you can search a drug by name, just put the name here, and or by therapeutic class, and if you click on show here, it will give you the unit cost, to give you a price, to give you a price of the drug, and you can also select for the year. So if you are looking for cost estimates, you can actually use these cost estimates. Now, if you want to do a study that's more locally relevant, you can go to a drug store, a national drug store, for example. So like in Uganda, where I've done studies, there's the National Medical Stores, and they produce a catalog. And this catalog has the prices of different drugs, and you can actually use that to get unit costs. So I just wanted to bring to your attention these kinds of resources that you can use when actually doing a study. As we wind down this week's videos, this last video for week 3, I wanted to also bring to your attention this method of essentially estimating personnel time. Estimating personnel time, and it's called time motion surveys, and I'm really fond of them because I like interventions that improve clinic efficiency, and they are used to essentially they're used to estimate personnel time, like I've said, but they follow the experience of patients within the clinic. So if you have a patient coming in, maybe you have a triage station. This is a clinic, you have a triage station. The patient goes and sees a nurse to take the blood pressure. Then they go and see a doctor. The doctor sends them to the lab, which is here. Once they go to the lab, they come back to the doctor. The doctor then sends them to the pharmacy. This is the pharmacy. And then they go home. You can estimate all these times. You can estimate the time from home to the triage station, but you have to use recall because you want to observe this. But in the clinic, you can observe. You can say maybe here they were between, first of all, when they arrived at the clinic, this is the gate of the clinic, maybe they waited 1 hour. And between triage and nurse, and then they saw the triage person for 2 minutes. And then they waited for 20 minutes. They saw a nurse, and they waited for 1 hour. They saw a doctor. Then they waited in the lab. Before going to the lab, they waited 15 minutes. Then they waited another 10 minutes. They saw the doctor a second time. Then they waited 2 minutes, and they saw the pharmacist, picked up their medication, then they went home. So once you know all those inputs, you can multiply these by wages of the lab person, of the doctor, both the waiting time and the contact time. Maybe the lab here you spent 3 minutes. And you can use these estimates to perform costing of interventions that involve human resources. So here's an example of a time motion questionnaire that I have used in some studies. And this is filled out by health workers, So the patient enters the clinic and, someone is going to initial. If it was me, I would initial here and say JBB. And then the time in, maybe the patient entered at 8. Let's say it's 08 and then 15. And there's no timeout because this is just entering the clinic, and then I'm going to sign, put my signature there. And then when they go to the second point of contact, they are seen by someone else who adds their initial. Maybe the designation here would be, maybe it's a nurse. Let's say this was a nurse, and the initial here would be NK. The nurse was called NK. They enter, maybe this is now 9000900, and then 0912, and then NK would put a signature here, maybe, and so on and so forth. And what would happen is that you would capture the time use by both patients and personnel. Patients as they wait, and personnel as they see health workers. And you can use this to estimate the time spent for interventions that involve personnel. Here's an example of a time motion study we've been doing in Malawi. And you see in this column you have the characteristic, you have waiting time and contact time. So you see that adults and children, adults wait a shorter time than children. And the contact time, adults see health workers on average for a longer time than children. And as you can see, the contact time are very small. Patients actually spend a short amount of time with health workers. They spend a ton of time waiting. So the waiting time is large. And as you can see, on Mondays, people maybe wait a little bit more than on Tuesdays and on Wednesdays, and they wait the most on Thursdays and Fridays towards the weekend. And people wait much more in the morning, usually because patients come very early to try and get in line early. But you know, one of the efficiencies we're recommending in this clinic is to set appointment times, to do community sensitization for appointments, although this is very difficult in a rural setting because essentially it's difficult to get the message across. Maybe they don't have telephones to be able to make appointments, and maybe, you know, the bulk of care is urgent care. So it's not like here in the US where I am currently, where before I go to the clinic, if I had anything wrong, I would have to make an appointment. So appointments might reduce this distribution from a lot of waiting time in the morning to smaller amounts of waiting time here later during the day. So this is an example of time motion estimates that you can use as the resource use estimate of personnel costs, of the costs of personnel. So as we finish, I would like to make a very important note about costing and accuracy. You need to trade off precision and necessity. Costing can be difficult, time-consuming, and expensive, and you have to make that balance between precision and necessity. For medical technologies like drugs and devices, these ones are sensitive to price. So precision in resource use and cost estimation is important. They're very sensitive to price. But in other studies, for example, intervention that affects hospital days, you may not need to estimate individual resources, and you can just go maybe to the WHO website and get an estimate of a hospital day, because that's unlikely to be price sensitive. So if you plan to do your own study, you have to be careful about spending a lot of resources trying to get a precise estimate of cost, and that consideration will depend on the question you're trying to answer. So with that, I hope that this third week, I hope that I've given you a relatively good flavor of cost estimation in economic evaluation, and that if you read a paper, you're able to distinguish which method was used for cost estimation, and you'll recognize and be able to understand the different terminologies used in papers, and that maybe if you're planning a study, you at least have a good start in terms of being able to estimate costs for economic evaluation. So thank you very much, and I'll see you in the next video, which is going to be week 4. And in week 4, we're going to look at the outcomes side the outcome side of the cost effectiveness ratio. So this week we are looking at the dollars and kwachas and Japanese yens, which are the numerator. And in the next week we're going to look at how to estimate outcomes, and we'll concentrate on QALYs and DALYs. So thank you very much.